For decades, getting paid in healthcare meant an army of billers fighting a war of attrition against payers, claim by claim, denial by denial. But what if AI could end that war before it started? Today, the CEO who bootstrapped her company from a kitchen table after watching AI fail from inside is here to show us what it looks like when the clinician, the platform, and the payment finally start talking to each other. Welcome back to HumanifAI HealthTech, where we explore how AI is rewriting the rules of healthcare and putting people right back at the center where they belong. I'm your host, Francesca Vereb, Head of Marketing at NetHealth, and today we're joined by Natasha Schlinkert, CEO and founder of Innobot Health, a revenue cycle management automation platform that uses AI to eliminate all that friction and slows down exactly how claims get paid. Now, Natasha didn't come to this problem from a whiteboard. She actually came from the inside of healthcare operations, watching AI fail, not because the technology wasn't capable, but simply because the logic feeding it was broken. Automate a broken process and you get a faster version of the exact same broken outcome. So she built Innobot Health from her kitchen table, laser focused on the place where clinical documentation and the platforms that capture it and the payment infrastructure that funds it either flows together or falls apart. Today, Innobot is actually a NetHealth partner. And on this particular episode, we're asking a question that nobody has answered. What actually happens when the clinician, the platform, and the payment finally start talking together? Now, Natasha, welcome to HumanifAI HealthTech.
Hi, it's so good to be here today.
First of all, I'm going to compliment you on your name. It's one of my favorites. My sister's also a Natasha. So that is just, again, really amazing to have you on the podcast today. Incredible story. Let's go back to a little bit of what started or your origin story. So AI companies in that healthcare space, as we said, are really built by technologists that tend to see a market opportunity. But Innobot, you did something a little bit differently. You really built that because you saw AI was failing from the inside. So inside, when I talk about inside, I'm talking about like the operational reality of getting specialty care paid for, essentially. So what were you actually seeing inside the revenue cycle operations that told you the problem wasn't the technology, it was the logic feeding it?
Yeah. So I started in revenue cycle management 28 years ago. Verifying eligibility, calling and fighting with payers on the telephone to get claims paid. And it went up through a supervisor, manager, director. I was VP of operations for a 250 hospital healthcare system, chief internal auditor for a 5 hospital healthcare system, COO for 2 different revenue cycle management companies. And in each one of these roles, I found that I had 15,000 employees onshore and offshore that just simply couldn't get to the small balances. We were behind on payment posting, and we had days in AR that we just couldn't explain. And so I hired a company 13 years ago to help me build automation, but automation really wasn't in healthcare. They had worked in banking and retail and finance, and so we started building, but the problem was we were trying to teach software developers revenue cycle management, and it was really clunky. It was messy. It took a long time. We eventually had a lot of success. We saw just over 1.3 billion in increased revenue in just over 18 months, but it wasn't without a lot of pain. Stayed and continued to automate for a couple of years and went to the next company, said the same thing, went to the next company and saw the same thing. So I started Innobot with 2 software developers in Sri Lanka and myself. And the first payroll, I think, was $900. And I was thinking to myself, Natasha, what have you gotten yourself into here? But we've been able to grow and help a lot of really great companies like NetHealth to serve their clients better. And what we found was that when you really understand the processes and you understand the pains and you understand the logic that goes into the revenue cycle as a whole, you're able to give the automation logic that makes sense for that next step that claim is going to go through.
I'm so glad you touched on some of the complexity there and, starting out with how you try to solve it. But then as you started to investigate the automation, because when a lot of people hear this like AI and revenue cycle, they tend to picture that there's this magic black box somewhere that's making decisions about their claims. But the reality is, as you started to touch on, that behind every one of those claims, there is a clinician who documented an encounter. There's obviously a patient whose care may depend on what happens next, right? So walk us through what AI is literally doing inside revenue cycle workflow. Like break down for the audience, what are the decisions that are actually being made and what does it actually start to free the clinician from so that they don't have to worry about this anymore?
Yeah, absolutely. When we think about automation or robots, software robots, we picture the physical robots that you can see. These are actually robots that work behind the scene. That is really a series of mouse clicks, keystrokes, and if-then statements. So if we think about training a new person in healthcare revenue cycle management from beginning to end, we are going to tell them, if this happens, then we need to do this. So for instance, typically we will say an order will be received from maybe a primary care doctor to a physical therapist. When that order is received, there are humans that have to go and look at that order, call the patient, get them on the schedule, but we can create automation that will look at the order, identify whether the patient's already registered in the system or not, locate the next available visits, send a text message to the patient and offer them those visits, and then go ahead and schedule it. That will kick off the next automation. So there's those if-then statements. If an appointment is scheduled, then let's verify eligibility. A lot of the systems have real-time eligibility via APIs, but that's only a small subset of data. 17 fields may be available, but each payer will supply maybe 9 or 12 of those fields. And so it's really limited. When we have automation that is replicating what humans do, and it's navigating to those payer portals, getting the eligibility, benefit level details, seeing if authorization is required. And then if authorization is required, there's our if-then statement again. Then we'll have the automation go and download all of the required documents, fill out the forms online, submit the authorization, check the status of that authorization and bring it back into the system. We're doing a lot of payment posting, claim statusing. If a payment is found, then post the payment. If a claim is no claim on file, go and check and see if there's an acknowledgement in the clearinghouse. If there was a denial received, create a templated appeal letter and download supporting documentation and upload it. So all the way from beginning to end, there are a lot of steps and processes that we're depending on people that we have to continue to add more people and do more training over time that can be automated.
So I'm going to double click on that just a second, and I'm going to simplify it for, marketers, folks like me in the audience, right? So what you're really talking about there is essentially 3 layers are starting to all come together. You've got a clinician, for instance, that's documenting for the patient. Then you've got a second entity where you've got the platform that's actually capturing all of those encounters. And then you have this payment infrastructure that you were talking about, and you were just describing a little bit there about like that adjudication process against coverage criteria. Now, the challenge from an AI perspective is that in history, these 3 things, these 3 layers essentially have operated in sequence, not in concert. And the gap is really where the money starts to get lost, right? And clinicians get buried in rework or pajama time or all sorts of things trying to reconcile. So what you just described with AI is so powerful, but what does it actually look like when AI starts to connect those layers in real time, right? And what actually changes first in that process?
Yeah, absolutely. So historically, prior to AI being involved in really connecting those gaps, what would happen is a claim would go to the payer would deny it for, let's say, insufficient documentation. Somebody in the AR team is working that account, and then they send it back to the coding team. The coding team will send it to the clinician. The clinician, on top of documenting all of their visits for the day, must then go back and review all of those and say, I don't really know what's missing. I documented everything that happened in that visit. But
And time is getting lost along that process, right?
Exactly. And then we have timely filing denials. We have multiple touches per encounter. That cost per touch gets really high. The ROI is gone. That gap between what it costs to operate and what we're being reimbursed has become so thin that we see so many layoffs and doors closing, and access to care gets pretty bad. So when we have the AI that's able to identify, here are the 5 elements that are required for this payer, then it can go back to the clinician and say, when you're documenting, please make sure that you include this, 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 and this. When the provider or clinician is documenting and there's a piece that's missing, it can alert them right away. You need to complete this, or ask them a question so that they can complete that documentation while it's still fresh in their minds. And then they move on and they don't have to think about it again. There's fewer touches per encounter. And there again, your ROI is increased.
That's fantastic. I actually had a situation with my daughter. She actually had to go through some surgery. And of course, it wasn't your standard surgery. So there were a lot of approvals. And of course, it started out with a bunch of denials. And it's so common to, having seen the behind the scenes because of the role that I'm in, I understood that probably what was happening is a denial was coming through as just a number, right? Just like a KPI on a dashboard or some sort of a flag as you've just described. But behind all of that, you still had the clinician who probably documented everything correctly. You had us, myself, my daughter, everybody waiting on the care. And then you've got the biller who's trying to fight this battle. Should it be approved, not be approved? And it's kind of ends up becoming this war that never needs to have actually started. So while we talk a lot about financial cost, and you just spoke a little bit about even ROI from a time perspective, which of course we can bring back to a financial cost too, what tends to not get discussed is that human cost, right? What is the cost there for the patient on the ground? And does AI actually change that, or does it just move the pain somewhere else? I wonder if that would have been involved in my daughter's process, if that had been a lot smoother. I don't think it was, because it took a really long time. But curious what you think about AI changing that from a patient's perspective.
Yes, absolutely. I receive EOBs sometimes where my claims are denied for my care. And having been in revenue cycle management basically my entire life, I understand that that's a battle that's being fought between the provider and the payer, but many don't. They don't have that inside look. And it can be nerve-wracking. When I see those, I also think, am I going to have to be responsible for this? How am I going to take care of that? I have a daughter of my own and a family, and I'm working, and we're all busy. And so then I think what happens in our society and our community is we put this mental blocker, this subconscious, I don't have the time, effort, and energy to do that. So unless I'm really dying, I probably don't need to go to the doctor. And we see that in America, we've really got a higher population of sick people, and we really shouldn't be at that place. When we talk about the pains that the patients are seeing, that's one aspect of it. But then we also see that a lot of times when our providers are trying to fight with all of this administrative burden that we're receiving from the payers, they are having to add more people, and there's a cost to that. And a lot of times you'll see that hospitals, physicians' offices are closing their doors, and that means less access to care, especially in rural areas. It's really challenging to find staff in those rural areas, especially that are experienced in the revenue cycle management and in healthcare. And so it's an even higher cost to have to relocate somebody to that area. It just has really become this huge strain on the healthcare system, and then essentially on our patients. And so, yeah, I really believe that the AI is the future. It's the way to go for us to be able to relieve some of that pain, and both in patients and in our providers.
You bring up such an important point, because oftentimes when we think about the notion of where AI is working quite effectively and just, standard applications, it tends to be after that denial process has happened. But you just brought up that a lot of people are just being put off by all the process and just the complexity. And so they're not actually going to the doctors. Now, that's a much more serious problem, right? So you've got a patient who's now waiting for care. You've got someone in the billing process who hasn't necessarily had that claim filed yet, and your clinician's moved on to the next patient. So do you see a point where AI needs to actually needs to intervene in the workflow earlier than before a denial actually happens? And what might that look like?
Yes, absolutely. So when we think about the triple aim, there was all of this accountability that came about. We needed the No Surprises Act, right? This is in an attempt to try to make patients feel more comfortable going to the doctor and handling those things. And so one of the things that we're automating pretty regularly with NetHealth, and NetHealth being the system that it is and has so much functionality, it really does provide us a great opportunity to look at the eligibility early on. So automation will run a report of upcoming appointments and look at that eligibility, calculate the patient's portion, can send a text message to the patient to say, we're looking forward to welcoming you to your appointment on Wednesday. Please be prepared to pay this copay amount. Patients feel that everything is handled and taken care of. I believe that they feel a sense of comfort in, hey, my doctor's on top of this. They've got everything streamlined. I don't have to wonder. I don't have to worry before I get there. I know that they're taking care of this. And so when AI partners with a really great, well thought through clinical documentation and patient accounting system like NetHealth, I think that really helps bring it together and close the gap and make the patient feel confident that they're walking into a physician's practice that understands what's going on and is able to handle it confidently.
I love that you bring that up. In fact, I think it's a really good reminder for those that are listening today, hearing you and hearing about all the amazing work that you're doing and the potential with Innobot. Let's talk a little bit about those folks who are thinking about, well, how do I leverage this? How do I apply that in my systems? So let's talk a bit about integration, right? So NetHealth specifically builds in these very specialized clinical workflows, be it, wound care, be it rehab therapy, etc. And we partner with folks like yourselves for the revenue cycle automation. And in fact, that's candidly how Innobot and NetHealth, as you mentioned, ended up at the same table. Now, the bet is that when these two things are genuinely connected, as in an integration, now you have that clinician that stops having to be the bridge between patient record, billing person, etc., as you mentioned in that workflow that gets really complicated. So what does integration give back to a clinician that two separate tools talking to each other might never be able to do?
Right. I think that we can see this in our everyday lives. Anytime that you're connecting something that wasn't specifically made for the something that you're connecting it to, there's always going to be some gaps there or a very large reconciliation process to ensure that nothing was missed. I think that it's really important when you're building to ensure that as you think about the revenue cycle as a whole, the visit, the patient experience as a whole, you're building in the platform from the very first step, thinking about what that next step or that last step would look like. And when you're building that last step, you're thinking about the first step and all of the steps in between. And when you partner with the practice management or EHR, for instance, if NetHealth is going to do some kind of an upgrade or some version control in the system, we're already aware at Innobot that this is going to happen. We're already testing in the back end to make sure that those automations don't break, to make sure that when that claim goes through that life cycle, it's going to seamlessly move into that next step. Anytime that you're adding on two separate companies that are not working together, the left hand will do something that affects the right hand, but they don't necessarily understand that that's happening. And so that integration and that partnership really helps to make that a seamless experience for NetHealth clients.
I love that you touched on that. And I think also, given that a big core part of this episode is really all about the fact that we're trying to remove friction with leveraging sort of a tool like an AI in the workflow kind of application to really help make sure that we're not only delivering care, but you're getting paid for it. I wonder if within the specialized sort of practice, like a rehab therapy environment or a wound care practice where, let's just face it, codes are complicated, workflow is complicated, it's highly specialized. I'd be curious what your take is on AI success, what it actually looks like within these specialized practices when that friction is now gone.
Yeah, I can actually give you a really good example. So we were working with a wound care group that was rounding at skilled nursing facilities. In this space specifically, it's really challenging to know whether that patient is going to be skilled or non-skilled. And even Medicare doesn't know until the facility bills for, let's say, the month of January, which the bill doesn't go until February 15th. So in that, a patient may be seen 2 to 3 times a week for debridements and wound dressing changes. And in that scenario, you're sending 15 claims before the payer even knows whether the patient's going to be skilled or non-skilled. So at this particular wound care practice, they had a 46% reopening rate, meaning they sent the claim to the insurance carrier, and as a skilled patient, insurance carrier processed, paid the claim. So now that's been posted to the patient's account. But then a month and a half later, comes back and recoups that money, and you have to do a corrected claim. So think of how many touches that is. The claim goes out the first time, somebody has to touch it. When it gets paid, somebody has to post that payment. Then when that recoup comes back, somebody has to do that. Then somebody has to correct and resubmit the claim. And then that payment comes back again. Now that's 5 touches that you're paying somebody. So we were able to use automation to go and look at the patient's remaining skill days, to log in and see if the patient is ST, PT, OT, sharing a room, on nutrition, all of the things that would make a patient skilled. And we were able to get that down to a 4% reopening rate, which resulted in several million in additional revenue. But then also all of those touches, all of that inaccurate information that's going back and forth. And when we think about the cost savings to the provider, we also think about the cost savings to the payers, right? So payers, when they have a lot of costs, the premiums go up, the patient feels that. And as a whole, as a country, the cost of healthcare increases even more. And so where we can make that impact on both sides and bring that down, I feel like we're really making a true impact in the world.
So you started to touch on 2 key things there, because we've spoken a lot about in this episode, a lot about the clinician, the platform, and the payment, those obvious pieces. And you started to touch on even the patient implications there, costs, and a couple of other things. How does AI now really empower and better serve a patient in this environment?
Yeah. Where a patient may have to call and wait on hold for a long time or ask a lot of questions, we're able to give them the No Surprises Act, right? We're able to give them what are they going to be responsible for early on. We're able to correct patient balances where there might be a credit on one encounter and open balances on another encounter where they're receiving inaccurate statements. We're able to really get those claims clean the first time so that they're not receiving those denials. And the provider's able to really focus on the patient and being present in that visit, because they're not thinking about how many corrections they're going to have to do to that documentation. They're not thinking about, whether they can keep the doors open the next day. Everything is cleaner and the patient gets better care all around.
So AI empowered clinicians are able to serve patients better is really your philosophy, right?
Absolutely.
That's wonderful. Okay, so we've spoken a lot about the good, But there's always, and you know this because you've built your entire career on making AI work where others couldn't, there's always a situation where maybe AI falls a little short. And better logic or better automation doesn't always mean that things are perfect. So even if, and of course you're very thorough and very detailed, so I imagine like all the right infrastructures in place with the clients that you work with and partners that you work with, but AI still gets stuff wrong, right? So, or there's maybe the other perspective is there are things that AI just cannot do. So where does AI still fall short in the revenue cycle, in your opinion? And what does it have to do in order to stay more human?
Yes. I think that human touch, the clinician asking the right questions, that piece is always going to be a human to human interaction. There are several things that I feel we're just not quite there yet. Never say never, because I'm sure 100 years ago, we would never imagine that we would be where we are today. But handwritten documentation. So things like anesthesia. The start and stop times are typically handwritten. And so those types of things, or where a clinician is documenting with handwriting, there are a lot of those shorthand things that we've tried to do to be more efficient prior to AI coming in. And those might be an L with a circle or a triangle. And those mean something to a scribe that's doing that. Currently, and I've tried probably 15 or 20 different tech stacks to try to get that to be really great, probably at 87 to 92%. But when we're talking about documenting a patient's care, to me, that's not high enough. It's not good enough. And I believe that we will get there. But today, I don't think that is perfect, and not perfect enough to really trust it. The next thing that I would think about is computer-assisted coding. When we talk about computer-assisted coding, it does well enough with reading the documentation and really understanding what the provider is trying to say. But again, it's still AI, artificial intelligence. It's still learning from patterns and trends. So if we say, with or without hypertension, and it only picks up hypertension, it could give an incorrect diagnosis. So while it can take 80 or 90% of that out of the way, we still need a human reviewing that computer-assisted coding. Payer trends. Payers are always changing. The only thing that stays the same in healthcare is that everything changes, right? And
costs more. That's the other thing. Yeah.
Exactly. So when we see that there's a change, AI is only working off of trends. Because I know that 98% of the time when this happens, this next thing happens, I know what I need to do. And that's how AI works. But if we change something completely, then we have to retrain that AI. And so having humans reviewing, quality auditing, looking over even the successful transactions and not just the ones that have failed, I think that's always going to be important. Humans will always be necessary in the loop.
Natasha, this has just been such a great conversation, and honestly one that really doesn't happen often enough. We spend so much time talking about AI in clinical care, but in many ways, the entire revenue cycle component just is as consequential. And so I wanted to thank you for joining us today and for helping us build something that really addresses an actual root problem. So before we jump into our takeaways, we're going to let you jump. And thanks again. I really appreciate your insight and appreciate you jumping on the show. And we'd love to have you back at some time.
Yes, thank you so much for having me. And I really appreciate this partnership.
All right, recap time. And here are the 3 things that stuck with me with my conversation with Natasha. First of all, automating a broken process just gives you a much faster version of the same broken outcome. And the organizations that she's seeing and we're seeing that have real results from AI in revenue cycle management aren't just applying technology to broken workflows, they're actually diagnosing and fixing the underlying issues first before they automate anything. It's almost slowing down to then go a little bit faster, which is great advice. Second, the biggest opportunity in RCM is proactive upstream prevention. So when AI is embedded where clinical documentation actually happens, denials can be stopped before they start, which means clinicians can stop carrying the weight of these billing problems, and that was really never theirs to have to solve in the first place. So less pajama time for sure. And lastly, the patient is the point and always will be. When the clinician, the platform, and the payment platform all start to talk to each other in real time, the result is care that moves forward without any friction for the people who ultimately need it the most. And that's the human behind health tech. And that's a wrap on what has been another enlightening episode of HumanifAI HealthTech. As always, I'd like to thank our listeners for tuning in. And if you're joining us on Spotify or YouTube, we'd love to hear your thoughts in the comments. And don't forget to leave us a rating while you're there. Once again, I'm Francesca Vereb, Head of Marketing at NetHealth, and I'll see you next time.